Hello, welcome in everybody. It is 11:30 Central Time. We're going to go ahead and get started here and jump in because we, as always during my webinars, have a lot to cover. I'm very excited to kind of dive into this information with you guys today with all of this. My name is Annalise Caffrey. I am a family nurse practitioner, and my background is specifically in geriatrics and preventative medicine. So I do a lot of our geriatric webinars, a lot of our screening guidelines, because I really love all of that stuff. That is super important, especially in a primary care aspect. It's a very important topic because it's something that you discuss every single day with your patients. Annual exams, we know, those are going to be the key times that we have these discussions. But even outside of annual exams, every patient encounter that we have, I promise you, there is a way that you can work in screening guidelines, preventative medicine. The United States is really trying to move on to a preventative approach. We're not taking that upstream approach rather than saying, hey, we know they've had 3 heart attacks at this point, so let's get them on a statin, let's get a bunch of stents placed. That's tertiary medicine. We want primary and secondary medicine where we're saying, how can we prevent these diseases from ever happening in the first place? Or when we look at secondary stuff, how can we catch them early, which is really important. The earlier we catch issues, the better we can treat them, the lower mortality is going to be. So this is going to close gaps in care regardless of whether you end up working in a super rural clinic or you are in an urban care facility. Talking about these screening guidelines and educating our patients is going to be crucial. Before we jump in too much, just have a little disclosure slide for you here. Nothing super important. If you're joining through the Zoom, you are eligible for a 1 credit contact hour or CE. That you do have to attend 80% of the course. So you've got to stay pretty much for the full hour of my webinar. So stick with me. I will keep it interesting and engaging, I promise. And you can get that CE credit. If you are joining today through Instagram or YouTube or TikTok, any of our other platforms, you're not eligible for that credit, but I post every single week the upcoming webinars, so you can sign up through our website and join through Zoom to get that continuing education credit. I know it's kind of buggy, but the only way we're able to actually give out the credit and know what email to send it to, etc., that you stayed the whole time, you have to join through Zoom. So if you want that credit, that's how to do it. Also, we don't have anything weird, no calcium supplements. We're not sponsored, no financial relations with any other individuals. This is just good evidence-based practice. I want you guys to know for your board prep, if you're in NP school, and also for actual practice as a nurse practitioner after you graduate. Learning objectives. Today, we're going to cover identifying age and risk-based recommendations. So when do we start screenings? We're going to look at some cancer ones, some heart ones, some bone density ones. We're going to differentiate between different screenings, how we apply them, and then using that evidence-based practice, what we can do for our patients by knowing proper screening recommendations. There's a lot of good apps, just as a side note, that go into screening guidelines, and I'll talk a little bit about some of those today, give you guys some recommendations, but also if you ever want to know more, you can reach out to me directly. I have a whole slew of work apps on my phone between UpToDate, USPSTF, the heart cardiovascular screening guidelines. I keep it all on there because that's the easiest way for me to get evidence-based information quickly. Moving on now, we're going to introduce Slido real quick. I know if you guys have joined any of my webinars before, Slido will be very familiar, but if not, and this is your first time, Slido is how I have you guys submit your answers. So since people are joining from TikTok, Instagram, YouTube, and Zoom, we have a lot of different people on a lot of different channels. The easiest way for me to get your guys' answers and your interaction is on Slido. So go to slido.com and you input the code screening, or if you're on your computer and you can use a QR code, you can go ahead and just scan this QR code with your phone and join that way. So I'll give you guys all a minute to get scanned and in our Slido, and we will start with a couple warm-up questions. We're going to use this throughout the entire webinar today to kind of go through practice questions for you guys to submit answers. So if you want the practice of submitting your answers, seeing if you're right before other people tell you the right answer, this is the way to do it. Okay, I'll give you guys just a second. First poll is going to be where you're joining from. I want to know where we have people here from. Are you guys joining from different states? I'm in Utah today. Florida, Central Florida. Oh, we've got another person from Utah. Where else are people coming from? Arizona. I actually was raised in Arizona. Another Floridian. Is that how you, I think that's how you say that, Floridian. Connecticut. Oh my goodness, another Florida. You guys got to all get together and study. We've got a little group going on. Western Pennsylvania. Awesome. My grandpa grew up in Philly. My dad was born out in New Jersey. Tennessee, I did grad school at UTK. If you're still on, tell me what part of Tennessee. I'd be interested to know. Another North Florida. Oh my goodness. Florida is just absolutely representing today. North Carolina, some of my best friends live out there. So happy to have you guys all in here. We will, Knoxville, yes, go Volunteers. That's where I did school. That's awesome. Great program out there, guys. Welcome, welcome in. Okay, that is our first poll. Now I want to know where you're at on your APRN journey. Are you a student and you're in your first semester of APRN school? You're about to graduate. You just graduated. You're already practicing. You're studying for your boards. Where are you guys at? You're studying for your boards for your third time. Don't be embarrassed about that. We cover it all. I've tutored all sorts of students from, this is their first time taking the test up to this is their fourth time taking the test. So no need to be embarrassed. They're studying for boards, already practicing, probably looking for those CEs. And you can always learn more about screening guidelines. So that's awesome. Congratulations. Graduate to taking your boards next week. Oh my goodness, get good breakfasts in this week. That's one of my biggest tips for taking the boards. Boards in 3 weeks. I'm a breakfast skipper and your body and your brain needs carbs on that day. So make sure you get a good breakfast, blueberries, yogurt, piece of toast, bagel. Graduate 2025, pass boards already. Congratulations. That is huge. That was just last month. So you cranked it out. That is really exciting, guys. I love to see it. We've got all sorts of people on the spectrum. That's awesome. Okay. One last question before we actually jump into the content today. I want to know how confident you feel about screening guidelines right now. I know we have a wide range of people that are students, just graduated, and already practicing. So I know we have the whole spectrum. I want to know how confident do you feel right now? Someone comes into your clinic, let's say you're in clinicals, you're practicing, and they ask like, when should I start screening? Or do I need this screening? How do you feel? About 6.4, 6.6. That's honestly not bad, guys. That's actually, I'm really proud of you guys. That's a good baseline to be at for screening guidelines. By the end, I'll ask this question again. We'll see if you guys feel a little bit more confident. Of course, I always want to see an increase in your guys' confidence level, but I'm really happy with this starting thing. I know a lot of schools emphasize screening guidelines because, like I said, the United States is taking such that upstream approach. Now we're really trying to improve. So let's jump into our actual content now with our webinar. Okay, first thing I want to do is introduce the United States Preventative Service Task Force. It's a mouthful, USPSTF. I am going to refer to it as that. If I mix up those letters, don't hold it against me because they just kind of, there's 2 S's, a P, a T, and F. They all really jumble together. But yeah, the USPSTF, they are how we find guidelines and how we know that they're evidence-based. So that is a really trustworthy place to start. I'm not saying they're the only one, but they are going to be who most of the recommendations we use in clinic in the United States are based off of. So the USPSTF states that they are a task force that works to improve the health of the people nationwide by making evidence-based recommendations on effective ways to prevent disease. That's going to be that primary prevention, and prolong life. That's kind of going to be where you see that secondary prevention. We're mainly going to focus on their A and B guidelines because that's their really strong guidelines. Anything that says A or B, they're telling you, hey, we have very strong evidence showing that this prevents disease or this catches disease early. It's going to improve quality of life. It's going to prolong life. You should do these. That's a moderate to high likelihood that there is a net benefit. So really important that we look at those. C or D, those are just kind of like, hey, there's some research maybe, or there's not any research at all. These are things we're going to look at. They have recommendations on over 80 conditions. This is going to be one of those things that I interrupt here in my webinar and tell you guys that it is very important that you have on your phone. So in my medical app, you guys aren't really super going to be able to see my phone, but in my phone, I have a folder that's called medical. And in that folder, I have literally the app that is created by the United States Preventative Service Task Force. So it is the USPSTF app. It's free on Apple, it's free on Android, whatever product you're using for your phone, you can download it. And what it does is you can search for recommendations by specific patients. So you can put in your patient's age, their weight, height, their sex, whether they're pregnant or not, if they're female, if they've ever used tobacco, and if they're sexually active. When you put all that information in, it is going to give you all the recommendations that apply specifically to that patient. Because I just told you, they make recommendations on over 80 conditions. Really easy for that information to get lost, for you to not know what applies to your individual. So you put here, yes, they used to smoke tobacco. It's going to apply those certain screenings that we do for tobacco users, specifically like a AAA, we assess for that. Lung cancer, all those things that we're going to apply because they've used tobacco for that patient. So that is a free app. Not a lot of medical apps are free. I mean, we know that a lot of these subscriptions get extremely expensive. This one's free. I would recommend everyone has this on their phone. You're going to use it in clinic, I promise. Moving on to types of prevention, this is another thing we need to know before we jump into the actual screenings. There's 3 types. This is going to be a refresh from nursing school probably, but there's primary, secondary, and tertiary, and they are kind of easy to get mixed up. When I say the word primary, I want you to think of that first letter, that P, as standing for prevent. So primary prevention, it is about preventing a disease. So that's going to be education, anything you can do before they have a disease, and then anything that prevents it, like vaccines. Vaccines will always be considered a primary prevention. Telling a child to wear a helmet when they're biking. That's primary prevention in an education realm. You're trying to prevent a traumatic brain injury from riding the bike. They haven't already had a fall or an injury on a bike. You're preventing that with the helmet use. As you can see from those examples, that's going to take place prior to any adverse events. Secondary, on the other hand, this is kind of the in-between. So something doesn't have to have happened, but the goal isn't entirely to prevent, it's to catch early. So secondary, S, think screenings. That's going to be where the USPSTF guidelines come into play. So we recommend screening mammograms. We recommend screening colonoscopies, pap smears. Those are all A and B guidelines that we're going to touch on shortly that we recommend should be followed because we know there's a net benefit. So remember, when utilizing primary or secondary prevention strategies, there's no sign or symptom of any condition. You don't know that they already have colon cancer. You're screening to see if they have colon cancer. So if you encounter a question that discusses any event that a patient already has, you can throw out primary and secondary. You know it already has to be tertiary because they already have this issue. So that T for tertiary, think throwback. That's going to be how you remember that. So T, throwback, S, screenings, P, prevent. Examples of a tertiary prevention would be working with a client to lower their A1C. They've already been diagnosed with diabetes, so they had that A1C over 7. Now we know, okay, they've got diabetes. What can we do to lower it? We are doing tertiary medicine. We're working backwards. They already have diabetes. We want to stop it from getting worse. Okay, moving on now to the actual screening guidelines. We're going to start off here with a pop quiz. Who can tell me the #1 cancer in the US that leads to death? This is going to lead into the first type of screening we're going to touch on today. So what is the #1 cancer in the US that causes death? I will let you guys take a second and put your guesses in here. I'm not grading these, but I will think you're super smart if you get it right. Okay, we've got a couple answers in here already for lung cancer. Anyone else disagree with that? Link, I love it. I'm queen of typos over here. I'm always moving too fast. You guys are exactly right. Lung cancer is the most common type of cancer that leads to death in the US. So most common death-causing. Skin cancer, we know, is the most common cancer in the US, but lung cancer is the most common death-causing cancer. So a little different there with words. If I told you it's the #1 death-causing cancer, I'm sure, therefore, you think, hey, we should probably catch that and prevent it. So it is imperative that we are screening our most vulnerable population for lung cancer, which I won't make a slide on this, but I'm sure to scream it out in your head or in your room. Who's the most vulnerable population for lung cancer? Are smokers. Congratulations, guys. Great answer. The USPSTF recommends that we screen every adult ages 50 through 80 that have a 20-year lifetime pack history of smoking and currently smoke or have quit smoking in the last 15 years. And I know that is a lot of words, but let's break it down for you a little bit. First thing you need to know is how to calculate a smoker's pack history then, because how do you find out that they're a 20-year pack history smoker? Is that just they've been smoking for 20 years? No. Pack history is calculated by multiplying the number of packs that they smoke per day times the years that they smoke. So if someone smokes 2 packs per day for 10 years, they have a 20-year pack history. So if someone's smoking 4 packs a day, that would be just a chain smoker. That is a lot of packs. That's an expensive hobby. 4 packs per day, it would really only take them 5 years of smoking 4 packs per day to qualify for that 20-year lifetime pack history. And remember, since it's lifetime pack history, we add up. So let's say they tell you, I mean, I'm not a huge smoker. Between the ages of like 15 to 20, I smoked 1 pack, 2 packs per day. And then, they came out with a lot of education. I stopped smoking. And then recently, from 60 to 65, I smoked 1 pack per day for those 5 years. So you would add, we know that from 15 to 20, that was a 5-year time span. They smoked 2 packs per day. So that's 10-year pack history. And then from 60 to 65, they smoked 1 pack per day. So they have a 15-year lifetime pack history. So remember to add up from different segments if they're telling you, like, yeah, they haven't smoked their whole life, but they did smoke during these segments. Now, the second part of that is the time frame of smoking. So the first thing you're going to do is if they currently smoke and they have a 20-year pack history, boxes checked, both those boxes checked, we do the screening. The other thing is if they tell you, oh, I mean, I used to be a chain smoker. I mean, from 10 years old to 20 years old, I smoked 2 packs per day. We know that that was a 10-year history, 2 packs per day. That is a 20-year pack history, but they never smoked again after 20. Well, do they need screening? We say then is that what we do is if it's in the last 15 years. So in that case, since they only smoked from 10 to 20 years old, they would not qualify for this lung cancer screening. It needs to be people that have quit smoking in the last 15 years. And do you guys remember what test we use specifically to screen for lung cancer? I'm not going to switch over to Slido, but just think of your answer in your head. It is a low dose lung CT. So we use, oh man, I already had the answer on the board. That totally gave it away, guys. But a low dose lung CT scan every year is going to be how we check for lung cancer. This is not a one-time screening. We have them get that low dose CT every single year. That is how we are good stewards of our screening resources. We've already decided, okay, not everyone needs a low dose CT every single year, but these people do, and they need it yearly. This is going to help us catch lung cancer. It's secondary. So it's not going to prevent it, but it will help us catch it. And hopefully we catch it early enough that our treatment options are better and quality of life is going to be better and prolonged. In addition to that low dose CT scan, we also recommend that any men aged 65 to 75, so only men, so the US Preventive Task Force has said that men are the highest risk. They're the ones that have evidence to support this. If they're 65 to 75, so in that 10-year span, if they smoke at all, if they ever have smoked in their life, even if it was for 1 year, 1 pack per day, between 65 and 75, we do a one-time screening with an ultrasound for AAA. So that abdominal aortic aneurysm is super high risk in men, especially white men. And we know that smoking increases that risk a bajillion fold. So it's really important that we screen for that abdominal aortic aneurysm with an ultrasound. They'll just do an ultrasound of the belly, look for any dilation of that abdominal aortic artery. And if there is, they're going to treat it. But this, once again, 65 to 75, any smoking history in men, we do the ultrasound. The last thing I'm going to say on this slide, I didn't write it in here, but counseling on smoking cessation is just gold standard. It should be done at every single visit for any patient that smokes. I ask them, even if 2 months ago they came in for their blood pressure check and they told me, nope, I'm not ready to stop smoking yet, I ask them again. There's a lot of new medications out. There's a lot of new situations, therapies we can get you in that will help you stop smoking. Are you ready to stop smoking yet? If they tell me no, I even push a little bit harder and I say, what is holding you back? What is stopping you from smoking? Because sometimes they'll tell me, I don't care. I don't care if I get lung cancer. I'm 75 years old. I'm fine with dying from that. I get too much enjoyment out of smoking to stop. But sometimes there's things that they're nervous about medications. They worry that maybe it will be too expensive and they can't qualify, or they worry that they've tried quitting smoking before and they weren't able to do it. So this is a conversation I have every single time. That is a grade A guideline from the USPSTF. And also for those of you that are already practicing, a lot of times insurances pay out. So you always chart and you add that as an E&M code and an ICD, nicotine addiction. And then you add in your codes there that you spent however long. I think there's codes for like 10 minutes, 15 minutes, 20 minutes or more talking about and counseling on stopping smoking. So that is going to help the insurance payout there for you and your patient to make sure everyone is getting covered as much as it can, that your clinic that you're working at is getting all the benefits from providing that counseling as well. Moving on to cervical cancer screening, another pop quiz for you guys. Any guesses for what the highest risk strains of HPV are? This is so testable. Boards love asking about this. I'm not going to tell you you're 100% going to get it, but they do love asking about this. So, what are the high risk strains of HPV, and then how do we prevent them? I will let you guys answer that one real quick. Give you a couple minutes. 16, great answer. 23, 16, 18, vaccinate. A lot of great answers in here, guys. 16 and 18, HPV vaccine. You guys 100% have it right there. The HPV 16 and HPV 18, those are the two most responsible. 23 is a cervical strain. It is not one that is as cancer causing. So when I'm asking specifically for the two most are on a test, I want you guys to know HPV 16 and 18. I remember that in my brain, and this may not work for you guys, but I'm just telling you what works for Annie's brain is I remember 16 to 18, that's like when everyone has started having sex, it feels like. In fact, I mean, research shows the United States, most people are losing their virginity or, starting sexual relations at that 16 to 18 age range. So I just think, oh, you got teenagers, 16 to 18 in high school. They're high risk for HPV. It is a sexually transmitted disease. So that's kind of how those two numbers stick in my head, because some of the other ones don't fall in that age range as much. It's not like there's an HPV 17, at least not that I know of. So HPV 16 and 18, those two even numbers, those are the most responsible for HPV related cancers. There are two other strains, HPV 6 and HPV 11. Those cause genital warts. So not great. No one wants genital warts, but not as cancer causing as 16 and 18. So they're a little bit lower risk. The great news is, like you guys said, we do have a vaccine that we can give to prevent HPV, especially in those high risk types. The vaccine is marketed under the name Gardasil, and it's been approved for up to age 45. And that has dramatically reduced the risk of cervical cancers caused by HPV. I know a lot of people used to think the HPV vaccine you could only get when you were young. It is now approved up to age 45. We know that it still can work. It can still help prevent HPV. And we know that those HPV 16, 18 are so cancer inducing that it is really worth giving them the vaccine all the way up to age 45 if they didn't get it when they were younger. I think we started about age 11 or 12. Here are the cervical cancer screening guidelines. This is going to be done during pap smear with this little lovely broom here that I'm sure every woman who's had a pap smear just loves to see coming. And what you're going to do is that pap smear is designed to detect abnormal cervical cells. We know that HPV, one of the reasons it's cancer causing is it changes the way our cervical cells look, especially under a microscope during testing, and that leads to cervical cancer. The screening guidelines have recently changed, though. The American College of OB and Gynecologists, or ACOG, they are the ones that most providers are going to follow. So that's going to be the most frequently done one. And they recommend that we screen all patients with a uterus, regardless of their sexual activity, starting at age 21. And that we screen every 3 years if the pap is normal, and only include HPV co-testing if the pap smear shows abnormal cells. So their recommendation is just do a pap smear every 3 years. So you start at age 21 through age 29, and you do just a pap smear, a regular cytology pap smear, and then you'll add HPV testing on later if that cytology comes back and says, yeah, there was abnormal cells. From age 30 to 65, because that's when those cells kind of start to get a little weirder, we have a couple different options. You can do same thing you've been doing, that cytology every 3 years, and add the high risk if they have abnormal cells. Or you can do co-testing every 5 years, which as soon as I turn 30, that's what I'm switching to, because I would only like to get a pap smear every 5 years. So you can do the cytology and high risk HPV, meaning they're going to test only for strains 16 and 18, like we talked about, every 5 years. So those are the two ones. If you remember that first decade after you all of a sudden start having sexual activity, every 3 years, and then every 5 years from 30 to 65 with that co-testing. Something of note here that really trips people up on board questions or test questions in class is that You have a patient come in who's 19, 20, 18, super really sexually active. Let's say she has 6 or 7 or 8 partners, whatever, or even just one partner. She's sexually active. Does she wants pap smear screening? Do we screen with a pap smear? The answer to that is no. Pap smear screening starts at age 21, regardless of sexual activity. That means on both ends. So age 21, they're not yet sexually active. We still start pap smears. Age 20, they are sexually active. We do not start pap smears. Those are started at age 21, regardless of sexual activity. So that is going to be your pap smear guidelines. American Cancer Society, I included this here because this is another set of guidelines, but I will say this is not the most commonly followed. So I would know ACOGs, it lines up with USPSTFs as well. So 21 to 29 every 3 years, 30 to 65 every 5 years, co-testing. We stop pap smears at individuals that are over age 65 if they meet this qualification. If they have had normal pap smears in the last 10 years, at age 65, we say, hey, you've aged out. You don't need to get pap smears anymore. It's one of the good benefits of aging. Also, individuals that have had a total hysterectomy, so meaning they removed the cervix and the uterus, if they only removed the uterus and left the cervix, they still need pap smears. So if they have done a total hysterectomy with cervix and uterus, we can stop that screening unless their hysterectomy was done as treatment for cervical cancer. So if they got a hysterectomy, even if it's a total hysterectomy with cervix and uterus, if they did that because they already had cervical cancer, we keep screening. One last thing to consider is if a patient has a history of serious precancerous condition, pap testing should be continued for at least 25 years after that was diagnosed. So if they find a precancerous condition or precancerous lesion, you're going to continue screening every 3 to 5 years for 25 years, even if that means that 25 years takes them over the age of 65. Moving on to breast cancer screening, another pop quiz for you guys. According to the USPSTF guidelines, at what age do we recommend discontinuing mammograms? So do you guys know when we tell people, hey, you're good to go, you've aged out, no longer do you need more pap smears? Wow, we got a lot of different answers in here. 75, 74, I'm going to assume is a typo. 69, 65, 75. These are all good answers. I will say, according to the USPSTF, it is 75. I know some guidelines may be a little different, but according to USPSTF, which is the most commonly used with the CDC, we stop at 75 and up. That is not a patient comes in, they want a mammogram at 76, and I say, nope, sorry, you're 75, you can't have it. This is when we start to have a conversation about stopping mammograms. I will tell you, I have a lot of patients that are in their 80s, they've had a history of breast cancer, or their family members had a history of breast cancer. They're very stressed about it. They have high dense breast tissue, and they're worried. They have a really good quality of life. They may still want to keep getting mammograms. So you just start to have the conversation, because we stop at 75 not because they're not getting breast cancer, but because research has kind of decided that at 75, by the time you get breast cancer, and with how severe breast cancer is, how many people die from it, you're still going to have a good quality of life, enough longevity that it isn't worth the treatments for breast cancer and the radiation from mammograms to keep screening you. So if your patient really still wants to get it, you've talked about risks and benefits, you've talked about quality of life, would they want to treat it if they got diagnosed with it? That's always something to talk about, especially as patients age. There's no purpose in screening if they say, yeah, if I found out I had breast cancer or colon cancer or osteoporosis, I'm refusing all treatment. Then you're just doing testing and misusing resources for no reason because they don't want treatment. So that's always a conversation you have with every patient, the risks and the benefits and what they would do with that knowledge. There are several sets of guidelines, like I talked about, that have been published. We're going to look at the USPSTF and ACOG guidelines first. Note here that the USPSTF guidelines changed just a few months ago, back in 2024, to match ACOG. So now those kind of all go together. I think USPSTF often defers to what ACOG says because that's kind of their specialty, their OBs and gynecologists. And so now those guidelines have matched. So what we're looking at is we start at age 40 to 45 depending on risk, and we do a mammogram every 1 to 2 years, depending on those risk factors. We don't initiate mammograms any later than 50 years old. So we get them started. We do it every 1 to 2 years. What's going to happen is after you get that mammogram, the radiologist that reads it is going to send back to you a paper, and it's going to say on that paper what the recommendation is. A lot of my patients have fibrous, dense tissue that is hard to read on a mammogram. And so my radiologist will come back and say, we recommend that they have a mammogram next year due to their risk factors and their breast tissue. Other times it will say, regular screening every 2 years. At age 75, that's when we once again have that conversation about discontinuing mammograms, just like we do for pap smears. I guess pap smears was 65. Ignore that. That was a misspeak. Just like we do for mammograms, where it's something they still can get cancer, but we talk about, do we want to discontinue those due to their risk factors, what their quality of life would be. Moving on to American Cancer Society mammogram guidelines and the National Comprehensive Cancer Network, you can see that these are the most aggressive screening guidelines, especially the National Comprehensive Cancer Guideline Network. They start really, really young. They're generally not followed due to there's really not a ton of evidence to show that it changes much, and the exposure to radiation at such a young age is really hard. So they really don't recommend that. But you do take into account on these, we initiate mammograms at these ages, this 40 to 49 and this 45 to 75, but that is based off of risk factors. So a lot of times for patients that we know, their mom was diagnosed with breast cancer at 35, the recommendation is that anytime you have a direct immediate family risk factor for those things, you start screening 10 years before that individual was diagnosed. So if mom got diagnosed at 30 years old, we would recommend that they start screening for breast cancer at 20 to 25 years old to catch it earlier because they have higher risk. Either way, I'm just going to leave it on this slide for a second so you guys can screenshot this or take this information down if you want. But either way, regardless of the guideline you're going to choose, you're going to pick one and stick with it because that's going to help you remember. I would, of course, recommend that you memorize ACOGs or the USPSTF. You also want to talk to your patients. We no longer recommend at-home self-breast exams that we used to recommend. We don't even really recommend clinical breast exams where we're palpating their breasts. It's always something I offer my patients because sometimes that's how they grew up. They still prefer to have someone check their breast tissue. But research shows there's really a lack of evidence showing that that is effective. What we teach now is we teach breast self-awareness. Breast self-awareness is this idea that as you don't need to palpate your breasts every single month in the shower and feel for lumps and bumps. Usually that makes women more nervous because we know that breast tissue is really just dense and fibrous and kind of lumpy. Fat is lumpy in and of itself. So it makes women really nervous about what lump's different, what's lump normal. What I teach them, especially women that are just getting breasts for the first time, their breasts are budding, they're developing, know your breasts. So palpate them then, feel what your breasts feel like so you know what's normal. If you know what's normal for you, you can then recognize what's abnormal for you. So just be comfortable with your breasts. Know what they look like, know what they feel like, what your nipple color is, and changes. Then you can look for dimpling, discharge, lumps and bumps that aren't normally there, that maybe it tracks with your cycle and we're less worried for breast cancer. Maybe it doesn't track with your cycle and we're more worried. If you know what normal is, your patient can then report abnormal for you. So remember, we always teach breast self-awareness. Quick break for you guys. We finished up with female reproductive screenings with pap smears and mammograms. I want to talk real quick about the Archer Review NP product so that you guys understand what we offer currently. You guys can use that QR code to join our community. We have that Instagram, like where I said I post all the links and the webinar times. We also go live on Instagram a lot. We have 2 Facebook groups. One of these groups right here, I love this group, the Pass the FNP one. It just has practice questions that we post every day. So if you just want practice questions, go ahead, sign up for that. We also are on TikTok, so you can catch those same videos and things there to save for studying information. But we have a really in-depth QBank. We have over 1,600 questions. We have a readiness predictor. One of the awesome things about our QBank is it's going to give you the rationales. I can say for upfront, I was working for Archer already when I was in NP school. And so when I studied for boards, I only studied using the Archer FNP product. That was the only thing I did. I watched our on-demand lectures. I did the Q bank. I passed with flying colors. I felt totally confident in my board prep. I felt like going into the test, I knew what I was doing. I knew the things I needed to know because all of the questions had rationale. So it didn't just tell me, yes, this answer's right and move on. It told me, yes, this answer's right. You missed it. Here's all why the wrong answers were wrong. It was really great for me to learn. I took notes while I was doing that. So I knew what further information I needed to watch videos on and study. We also host 3-day live reviews a couple times a year. That's going to be these virtual live events where we go body system by body system and teach you guys about what you need to know. And then also, this is a newer offering, these clinical skills. We rented out a hospital setting with hospital beds and simulation labs, and we professionally filmed for you guys over 200 clinical skill videos, things like suturing, things like musculoskeletal tests, like the valgus stress test, like anterior drawer tests, because demonstration is a must for a lot of these clinical skills. Teaching you them in a webinar or in a PowerPoint is just not effective. So if you want to sign up right here, you can go to nurses.archerview.com/FNP and you can sign up for these products. We have very affordably priced them because we know no one is rich in NP school. I was broke and eating off top ramen, just surviving till graduation when I could get a real job. And so take advantage of our well-priced product. You guys are going to love these. And I stand by the products because it is what I used. I'm not coming and saying, oh, I used a competitor, but buy my product. I used this product. I passed. I felt very confident. Moving on to colon cancer screening, I have another pop quiz for you guys. What age do we start colon cancer screening? So I know for mammograms is when do we stop? What age do we start? And this is a little bit of a trick question just because I know you guys are going to say, well, it's going to depend on their risk factors. But let's just say for the average population, what age do we start colon cancer screening? 40, 45, 45, 45. Good answers, guys. The right answer is actually 45. We start screening for 45. That is actually a recent change. It used to be 50. So the person who said 40, maybe in 5 or 10 years, you will be right and they will decrease that age again. That is because colon cancer, it is the second leading cause of cancer deaths in men and women. And something to note here is that people younger than 50, colon cancer is on the rise. It's rising 2.4% every single year. So we are getting better at treating colon cancer. We're getting better at catching it early with colon cancer screening. But the incidence, usually we think it's due to our diet and the lack of fiber in the American diet. It is happening more and more. And that is why it is so important that we make sure we're hitting these screening guidelines, that we're starting them at 45 or even earlier based on their risk factor so that we can get patients help. There are 2 pathways to screen for colon cancer. We have the colonoscopy, that's going to remain the gold standard. And it is invasive though, and they have to have bowel prep, and that means they're sitting on the toilet all night long. They also have to have anesthesia, which means they need a driver to pick them up. So it's a little bit more complicated, a little bit more expensive. Usually both of these are covered by insurance, but if they don't have insurance or they have a really large out of pocket, maybe it will be a little bit more expensive. The other option is fecal sample tests. The great thing about a colonoscopy, though, is that after your initial colonoscopy, usually you're going to return about 10 years. If you get the full colonoscopy, not the sigmoid colon, just the full one. If you don't have any polyps or any precancerous spots, they'll tell you you don't have to do it again for 10 years. If you do have polyps, a lot of times they'll have you return in 5 years, but that's still not too bad. On the flip side, those at-home screening kits like fecal sample tests, they are really only appropriate for lower risk individuals. So that has to be someone who has never had a polyp on a colonoscopy and they have no family or personal history of colon cancer. If they have any of those, they have a family history, personal history, or they've had polyps, they're really not appropriate for those at-home screening kits. They need to have a full colonoscopy. And there are several at-home kits on the market. There's Cologuard that detects blood in the DNA or in the stool. That's a mail-in sample, makes it really easy. They collect it at home because no one wants to have to take their stool sample into a store. This way you collect it at home and you mail it off. But those tests, they have to be repeated about every 1 to 3 years on average. So with that, it's going to be a lot more frequent. So less invasive, but a lot more frequent. And it isn't for everyone. Plus, if the stool sample ever reflects a positive result, then you also still have to get a colonoscopy. So it doesn't save you a ton of time other than maybe if it doesn't show blood, you don't have to go get a colonoscopy. But if it does, you still have to go to the GI and get further testing. Either way, with colon cancer screening, the takeaway here is that Early detection is key. It's why we're decreasing the age. Colon cancer is on the rise. Colon cancer deaths are also on the rise. We want to catch it early. Moving on to bone density, this is going to be our final mention. Bone density screenings, they're detecting osteoporosis, osteopenia, and then they're going to stage the decreased bone density before osteoporosis. So we can kind of see how far along are they? Is it getting worse? Bone density screenings are currently done using dual energy X-ray absorptiometry. No, I said that wrong. Anyway, it's dual energy X-ray absorption. It's also known as a DEXA scan. That's where the name DEXA comes from. It is used to screen almost exclusively postmenopausal women aged 65 and older for bone density. This is not as much recommended for men unless they have specific risk factors. And even then, we do it a little bit older. We start at 75 for men, and they would need to have severe risk factors like they've had a pathological fracture in the past or a strong family history. The reason that we screen women so much more than men with the DEXA scan is that after menopause, that estrogen level drops, and estrogen is so important for bone health. It plays a big role in calcium and bone resorption and bone creation. And so when that estrogen level drops, our bones become more fragile, a little bit like a stale croissant. So we screen younger and more often in women. So that 65 and older, we screen about every 1 to 2 years. And we even screen at a younger age before 65 if they have risk factors. So if they had early menopause, if they have a family history of osteoporosis, if they have pathological fractures, if they have frailty syndrome, things like that, we're going to screen younger than 65. But at 65, for every woman, we screen about every 2 years. Kind of like mammograms, the radiologist will come back and say, no, with their T-score, we should screen every year. A DEXA scan is going to then assign a fracture risk assessment tool, or that's called a FRAC score, with the normal risk of a fracture being less than 10% in 10 years. What it does is it's looking at your T-score and it's telling you what is the risk factor that in the next 10 years, this person has a fracture of the hip or just another major osteoporotic fracture. With T-scores, what you're looking for is that less than -1, that's good, healthy bone. From -1 to -2.4, we're looking at osteopenia, and greater than -2.4, meaning kind of less than, so like -2.8, -3, that is all going to be considered osteoporosis. And the negatives make it a little confusing, so just make sure you know that osteopenia and osteoporosis, we're both talking about negative numbers. For FRAC score, recommended guidelines suggest that we start treating patients if their FRAC's 10-year risk score is 3% or greater or 20% or greater for any other major osteoporotic fracture. We do it a lot less of a percentage for hip fractures just because we know that hip fractures take so long to recover from and are really dangerous. So we have a lower threshold for treatment there if their hip is more porous. Because the thing to know is that just because your bones are a -2.8 at your hip doesn't mean that they're a -2.8 everywhere in your body. Our bones all absorb and build bone differently. So they may be very osteoporotic in their hips, but then they're totally fine in their humerus. So it's important that we're looking at those results and what the guidelines are for treatment. And treatment, of course, is going to start with calcium and vitamin D supplementation. And then if that doesn't work, or if it's very severe, or they have a risk of fractures in the past, that's going to be where we move on to Fosamax, those aldrogenate drugs that are going to help with bone. I think that's everything there for bone density screening, guys. If anyone has any questions, feel free to drop them in the chat. But until then, we're going to do 2 practice questions for you guys with screening. This is your first question. A 52-year-old woman has no significant medical history. She presents for a wellness visit. She's never had a colonoscopy before, asymptomatic, says she has no family history of colorectal cancer. What is the appropriate next step? I'll switch over here to our Slido. We can take a look at this one together. Do you think A, it is to begin annual fecal occult blood testing, the FOBT? Is it to order a colonoscopy and repeat it in 5 years? Is it to schedule a screening colonoscopy every 10 years? Or do we defer screening until age 60 since she has no family history? Give you guys a little bit longer. We'll see how everyone's feeling and how we're doing. I'm seeing a lot of answers being submitted. Looks like people are kind of fighting in the numbers between that colonoscopy every 5 years and the colonoscopy every 10 years, as we actually look at it and the rationale here, that correct answer was to schedule a screening colonoscopy every 10 years. That's because remember, we start at age 45 for someone of average risk, which she is because she doesn't have family history and she has no symptoms. And we schedule it for every 10 years. That's the preferred screening method. I know we talked about 5 or 3 years. That is going to be recommended by the provider or the surgeon who, I don't know if you call him a surgeon. Anyway, whoever did the colonoscopy, they're going to make the final judgment call based off of polyps and if they were precancerous. And so maybe it will be shortened to 5 years, but that's going to be abnormal findings or they become higher risk. Other than that, we do it every 10 years. One more practice question for you guys. Now you have a 36-year-old woman. She presents for a routine exam. Her last pap smear was 3 years ago, shows no abnormalities. She has no history of abnormal results and is in a monogamous relationship. What is your appropriate next step? Are you going to A, repeat the pap smear alone now? Are you going to defer screening until age 40? Are you going to do a pap smear with HPV co-testing? Or are you going to repeat the pap smear annually? Two of these are kind of appropriate. I see what you guys are fighting about in the comments there. Two of them are kind of appropriate, but what is the recommendation? Is it the co-testing or is it just doing a pap smear alone? Okay, I think everyone kind of got a chance to answer there. The right answer is that co-testing. We do recommend co-testing every 5 years from 30 to 65, or you can do the pap smear alone every 3 years, but co-testing is always recommended if it's available. So that was kind of a trick question because it says the most appropriate next step. A pap smear alone is an appropriate answer, but the most appropriate and what is recommended by the USPSTF is that co-testing if it's available. So we always start there. Okay, guys, I have some time for questions now and to give you guys just a little bit more information. First, we'll start with this screening here. How confident do you guys feel after going through those? Did I make things more confusing for you or did I improve it? Eight 8.5, 8.4 right now, 8.2. That's a good increase, guys. It's sitting at 6.4. We've got like a 2-point increase here in confidence. So that's what I really like to see. A lot of times it's just going through these. And like I said, getting those apps that are going to talk about how we screen, what we do, and what's helpful then for our patient. So that was awesome. Next poll, I want to know what questions you have. Drop any questions you have about screening, or you can even drop another question if I have time for it. I can try to get to it. If you have a question you want me to answer, it could be about our product, what products we're launching in the future, what you want from Archer, and even just what questions you have about screening guidelines if you have any. I'll give you guys I'm going to give just another minute for people to think of a question if they have one that they want answered, a burning question that they need to know. I will give just a couple more seconds there. But the last thing I wanted to come over and let you guys know, the next question is going to be what future webinars you want to have. So be thinking of that. If you don't have a question you want me to ask or answer, I want to know, what do you guys want to hear from us? We do like 2 or 3 free webinars a week, and what is going to be best? When is the next 3-day live review? We are getting that question a lot. A non-demand 3-day live review. I actually can get you access to a non-demand 3-day live review. Right now, we do not have a 3-day live review on the calendar. We're working on getting one scheduled. We just want to make sure it's at a really good time for you guys, for people taking the boards, and that it's going to be the most effective and useful. We're kind of revamping all of our products right now. And our Q Bank's going underneath a revamp. We're adding questions. We're working on this really awesome launch. And so with that, I want to make sure that we are getting you guys all the information that you need and want to have. Coding and billing. Okay, I'll talk about that one in a second. The courses that have CE hours are going to be these webinars, and I usually post on Instagram or Facebook. I'll let you know they're usually 1 CE credit hour per course, and I'll let you know that ahead of time. You guys can sign up during Zoom to get that. With on-demand versions of the product, there is an on-demand version of the product. If someone's looking for it, you can go ahead and reach out to us on that email. I'll put that email back up again, but it's just nurse practitioners at archerreview.com. So if you email nurse practitioners at archerreview.com that you're looking for that, I can get that over to you guys. Cardiovascular disorders, a live webinar is actually happening this week. We're covering hypertension and cholesterol issues specifically. So if you want to join that, Hiva is presenting that this week, and I'll let her know you love the cardiovascular issues, you want more on those disorders. As far as coding and billing goes, I think that is a webinar I would love to get going again. I know we've done it before in the past, but when I graduated, that was what I was stressed the most about, especially since it's such a legal thing, billing properly, or not billing properly. And so I was so stressed. I was like, I'm putting these codes in wrong. I'm not, or not putting all the right codes in, or the diagnoses, and retiring old diagnoses. There's a lot to know in the insurance aspect about APRNs that isn't taught to us in school usually in depth. And so I will put that on the list and make sure we get something going for you guys soon. I think that's everything, all the questions there. If you have any other questions, the on-demand courses do not currently have CE hours. So that is something we are in the works of, is getting CE credits added. So for those on-demand courses, so you can do them on your own time frame. We are launching a really big product right now. That I'm excited about, that should be coming out shortly. So that's going to be really crucial for you guys while you're in school and looking at maybe adding CE hours to that. A CAD disease, I'll write that one. CAD, diagnosis, treatment, and management. I'll get that one down. Okay, guys, these are great ideas. Thank you so much. I was so happy to give this webinar. Thank you for joining. I will end here with this slide one more time for you guys that need it, that want to find our socials, sign up for our courses, nursesarcherreview.com FNP. If you just type in FNP Archer, it's going to pull up in your browser. And this QR code here will take you to all of our socials so you can connect with us. And once again, like I said, nurse practitioner at archerreview.com is going to send your email directly to me. I am the team lead for the advanced practice program, and I can get all the information that you need. I'm out there to help if it's private tutoring, whatever you guys need. We are here for that. Thank you guys for